do example of tension pneumothorax, needle decompression. We're using Luke here as an example. We're assuming he's got a tension pneumothorax, he's got all the signs. Respiratory difficulty, this part of the chest is greater than the other side. It's all in my notes there, that the various signs for tension. Okay, so we're going to look at the landmark there. The landmark we're looking for is the second intercostal space mid-clavicular. We go down from the suprasternal notch, we go down the sternum until we find the first bump, this notch just below the suprasternal notch. We go, that's called the angle of Louis. Okay, we run our fingers across, and that's the second intercostal space there, just there, and we're looking at mid-clavicular. So that's the whole clavicle right here to the shoulder. So up around here, we're quite happy with that, and we feel the third rib just underneath there. What we can do is mark the area. Okay, do it across there, mark the area where we're going to insert. Apply a swab, bearing in mind that sometimes we have to do this very quickly. So just swab the area. Okay. Obviously explain the procedure to the patient if they're conscious. If they're not conscious, then obviously we just do the same procedure. What we normally use is a 14 gauge Jolko, or we can use there's various sorts of other cannulas available for chest decompression. The main thing, they're generally about 14 gauge. The main thing that a lot of these have is the needle's longer. In this particular case, we have a needle in a sheath that's essentially a large cannula. This also comes with a little knife. We can, if we wish, we can just sort of do a subcutaneous cut around that area. But in most cases, it's not necessary. So what we're trying to do now is where that mark is. Identify where that mark is. We're going to insert the needle, okay, perpendicular to the chest, okay, above the third rib, slightly above the third rib, okay, and slightly towards the vertical body, okay, and we just insert that straight in, okay. We insert that straight in until we feel a bit of a give or a bit of a pop, indicating that it's within the air cavity that is the tension, the air cavity, and then we can, once we've determined that, we can take the needle out. Okay, we have a sharps container there. We make sure that there's nobody around, that we eyeball everybody, so sharps out. There's no risk of a needle stick injury. We take the sharp out, insert that into our sharps container, okay. And the next thing we'll do is we've got to secure this catheter, okay. The way we do that is we can put an opside around there, we can run some tape around there and tape that in, okay. We just generally leave that in there until the tension is completely relieved. Okay, thank you.